Welcome to another episode of the Federal Newswire Lunch Hour podcast with your host, Andrew Langer.
Well, hey there, everybody. Welcome to another episode of the Federal Newswire's Lunch Hour podcast. I'm your host, Andrew Langer. So grateful that you're joining us today. If you're watching us on our YouTube channel, you know you can take us wherever you want to go by listening to us on one of the many fine podcast platforms out there that carry the lunch hour. Just about every fine podcast platform that's out there, or even ones that are not so fine. If you are listening to us or watching us on our YouTube channel, I've said that. If you are listening to us on one of those fine podcast platforms and you want to join us in studio, go and check out our YouTube channel. Please hit the subscribe button, hit the like button, leave us a comment, send us an email, and let your friends and family members' friends know all about how much you're enjoying the lunch hour. Joining us today, we're honored to have Nick Gerhart, the Chief Operating Officer of Homesteaders Life Company, with us. He stepped into the COO role in February of 2024. Bringing a wealth of experience from his previous positions at Homesteaders, their Executive Vice President and Chief Innovation Officer, the Chief Administration Officer at FBL Financial, and notably as the Commissioner of the Iowa Insurance Division, a graduate of the University of Northern Iowa and the St. Louis University School of Law. Nick is also deeply committed to community service, contributing to several different nonprofit organizations. Nick, so glad I can have you on and you can join all of us today. I mean, let's dive right in and let's talk about your work as the Chief Innovation Officer at Homesteaders and this issue of innovation and how it informs products that best serve the public. Let's talk about that and why we need this drive for innovation, especially in areas like insurance.
Thanks for having me. It's great to be with you. I would say, Andrew, without innovation, businesses are going to die. Customers are not going to get served well. We don't keep up with the needs. In insurance, you don't think of innovation in insurance, right? It's a highly regulated industry. A lot of companies are 100 years old or more. But I would say, when all of the fintech, insurtech kind of wave started about a decade ago, I was involved with one of the first accelerators ever created that focused on insurance. And really the reason is that, Iowa is an insurance state. The state of Iowa has some of the largest insurance companies domiciled here. One of my commitments to Governor Branstad at the time was we really need to make sure the industry's here and growing for the next 100 years because there's too many people in Iowa that need the products but work for the companies. So from our standpoint, you have to continue to innovate because there's always someone coming up behind you and there's always someone that's got capital, that's got a good idea, that's going to try to disrupt your business. And really for the carriers, we all have the data, we have the expertise, we have the people, the distribution, but we may not be able to meet the customer's needs where they're at. And if you think about insurance, we have to make it simpler, easier, more affordable. All of those things need to happen so a consumer will buy our product. You don't wake up typically and say, I want to buy insurance today, no matter what line of insurance it is. At least most normal people don't. So really, it's imperative that the industry always innovate and transform because how we did business 20 years ago is not what's going to work today. It certainly won't work 5 years from now or 10 years from now. So I think innovation is really the life and heart of most of these companies in terms of continually meeting the demands of the consumer. But again, it's meeting that demand of the consumer, meeting where they're at, helping them understand the value prop you offer, and making the process as easy as possible. It's still regulated. It's still a lot of hoops consumers have to jump through, but it's a great opportunity to meet those needs.
I mean, there's so many places to go with this because we're going to talk about health insurance, which, I mean, let me ask you this as sort of the outset, because I don't think of health insurance as insurance in the traditional sense, right? Insurance is a hedge against some event. Whereas health insurance is really about cost sharing. And that changes the calculus in terms of, it shouldn't change the calculus in terms of innovation, but when you combine that and the economics behind it with the issues of regulation and competitive federalism, let's just start with the basic question. Health insurance is or is not different than other kinds of insurance?
Well, I think you're scratching on something that's pretty profound, actually. I would say it's still insurance, obviously.
Sure, of course.
There's still some risk transfer. The issue, though, is that it has become more of someone's going to pay for what I need done. and the demands that both consumers, employers, I would argue government programs, quite frankly, have put on the healthcare system are pretty taxing. My dad was a family
No pun
physician.
intended.
Yeah, exactly. No pun intended. My father was a family physician for almost 40 years. When he started, he had the old proverbial black bag, would go do the house calls. By the end of it, he was willing to pull any of the hair out he had left, right? Because of all of the demands put on him as a sole provider of healthcare services in our small town. So I think that when I think about health insurance, and I've worked for 2 companies now where I kind of oversee our health plan, it's a self-insured plan, and you're trying to negotiate on behalf of your employees for good coverage, but at the end of the day, it has become really an interesting dilemma, because if you think about your car insurance, right?
Yes.
You don't expect State Farm to pay for your oil change. You don't expect State Farm to pay for your tire rotation. But when it comes into healthcare and health insurance, there's all of these things that people demand, certainly once you meet your deductible. And then, and if you've ever talked to someone on Medicare, once they meet their deductible, watch out, and again, it's a bargain that they have, but they know no bounds of what can be spent. And I say this as someone who's working with several people on Medicare, and it serves them fairly well. But to say that it's been a risk transfer or that there's anything there, enough cost burden on the consumer, no, there's not. And so we do have to step back and look at, traditional insurance is definitely a little bit different. You can look at your homeowners and say, I want a $500 deductible and you'll pay a lot more. I'll have a $10,000, and you can start to, put the risk on yourself more to bring down your premiums. There is a move a little bit towards sort of these higher deductible plans, but honestly, under the ACA, that's been a little bit more challenging.
Right.
In the employer market, you can put in HSAs and have more cost burden and sharing to the folks if they want to so do that. But I would argue that sort of the plan design and flexibility in the individual market, and maybe even the small group, has really been challenging, to say the least. So I would say that it's still insurance, but it's not, to your point, you kind of nailed it. It's not your typical insurance like you would have for your personal lines, home, auto, et cetera.
Right. One of the things that I like to say in terms of this, right, is, and I think when you and I talked before we did the interview, I mentioned this, right, in other situations, right, if you're talking about the auto industry, and even assuming for a moment that you would use your auto insurance to get your tires rotated, but let's say you bought some kind of a maintenance plan on your car. When these companies are out there and they have, right, there's a finite amount of resources that are out there. If they're running out, or if they want to bring down the cost, they want to make themselves more competitive, right? They can go and they can order more tires or more mufflers or more fan belts or whatever, like pick your part of the car. And there's some manufacturer that is going to ramp up and produce more. When it comes to health care, right, the widget is the doctor's time. Or the medical care provider's time, right? The amount of time that someone spends, and sometimes it gets to the devices, procedures, et cetera. But at its core, right? And the problem is, we are not making enough. We're not making enough doctors, nurses, or physicians assistants. We have a declining number of doctors at the very least. My wife is a family physician as well, like your dad was. And so that's an issue here. And so it makes the challenge of innovation and competition all the more important, doesn't it?
I think it does, because again, you have a wave of retirements, and I would argue the pandemic probably accelerated retirements in the medical community. I don't have the exact data on hand, but I know anecdotally several docs in their late 50s to early 60s that punched out when I don't think they were thinking they were going to punch out that early, Andrew. So and then you have not as many kids that are going into med school, and just the length of time it takes to get in the program, residency, and like I always say, that individual to make it through med school, make it through residency, in nursing school is the same way, PA school, they put a lot into their intellectual capital, and they should be compensated for that, and they've earned that right to charge for what they offer. But if you think about where we're going, and if you've been to the ER, I'm in Des Moines, Iowa, great community, love Iowa. But I've had to take my youngest to the ER in the last 2 years, and I'm telling you, it was quite the experience.
Right.
It was full. Unlike anything I'd seen, and when I talked to the doc on staff, he's like, it's like this every night. And so, there's definitely a problem, and maybe it's staffing. Some our beds are full, all kinds of different things like that. But you need to have innovation, and I always say, really, where I think the most interesting things on innovation really is in the data to help people avoid these catastrophic events that put you in the hospital. It's your wife, preventative medicines. I'm a big fan of that. Going and getting your
100%.
annual screenings and doing all that's really important. Unfortunately, I know a lot of people, recently that don't trust the medical community as much. Unfortunately, they're not going to the doctor. So,
Right.
It's all over the map. But I think at the end of the day, we do need that data and the ability of artificial intelligence and machine learning algorithms to help on a real precision method basis. If you have, and I just helped somebody do this recently. Somebody had an event they were experiencing. They put all their symptoms into ChatGPT, which I'm not sure I would want to do that, but this person did. And it came up with a plan, So this is the kind of stuff where artificial, and again, that's not your doctor, but it can have you have an informed conversation with your doc.
Well, it's I know doctors get driven up the wall by Dr. Google. On the other hand, the problem, not the problem, but the reality is that these kinds of technologies are getting better. I'm a big fan of an AI platform called Perplexity, and it's done great work for me in terms of pulling together data in a way that other search engines have not. So we may be moving towards that, but which gets into this issue. Part of the reason, folks, why Nick and I were sitting down today was because we want to talk about competition across state lines in terms of health insurance products. But let's sort of get at this issue of the push-pull, as I like to call it in public policy, which is we have these federal solutions to things, but then we have to remember that health insurance, like other kinds of insurance, is regulated at the state level. Let's talk about why that is and whether or not that's still a model that needs to be done or how that changes over time. Let's talk about that.
Yeah, obviously for many years, since 1945 McCarran-Ferguson Act, insurance has been regulated at the state level. I was an insurance commissioner, so I've been behind those closed doors. I've had the job, have the T-shirt still, and all that. I think that the state-based system works fairly well in a number of respects. One is for the financial solvency. I always say the job of a commissioner is really twofold. It's ensuring the solvency of the carrier so they can make the claims, and it's also kind of the kitchen table helping consumers with complaints. I definitely think states are a much better avenue for consumer complaints because I would always joke, I actually had to see these people in my community. I see them at the grocery store, at church. So you are very responsive. I think getting responses out of Washington, D.C. when I was commissioner, I had a hard time getting responses out of HHS. And I was commissioner and I'd have to have the governor call sometimes. I do feel like at that level, it's pretty good. The question I think it's fair to ask is when it becomes sort of there's issues of potential anti-competitiveness or there is some hurdles in getting across state lines. Maybe there's carriers that are, certain size. After the financial crisis, there was a move to basically have these globally systemic groups be dual regulated kind of at the federal level and state level. And there was some harmony there, but honestly, it kind of created duplicative efforts and really taxed those carriers, quite frankly, a little bit extra than they should have been. But I do feel like there's definitely been a move in many states to realize the job's important. They need professionals around them. You need to have a chief actuary. You need to have staff to do the job. And then you have the ability to leverage, experts that only work for regulators. But I do think the state-based system works still today. I do feel like there's definitely some strays. There needs to be some more harmony on how the market reacts and is treated. But I feel like on the solvency side, they still do a reasonably good job.
Well, let's talk about this. So there's that aspect of it, but there is this push. Now we deal with, what is it? It's a $5 trillion industry in the United States, right? Is health insurance.
It's if you look at healthcare spending, it's right around $5 trillion.
Healthcare spending is $5 trillion. Yeah. Thank you. And so the idea is, one of the ways to get at the issue of costs is to create competition amongst, interstate competition, allow insurance to be issued across state lines. Let's talk about the economics of that, and then we'll talk about the regulatory challenges that are at issue here.
Yeah.
And again, recognizing that it is 2025, and we have these things called AI that can certainly help with a lot of the grunt work. But let's talk about why this is important.
So, when the Affordable Care Act was passed, I believe it's Section 1333, there was a provision, and I joke, I'm probably one of the only souls that actually read the entire Affordable Care Act.
Sure.
But, there was this idea that you could have these state co-ops. So like Iowa could partner with South Dakota, Nebraska, and I believe 7 or 8 states looked at doing that. I don't think any group of states did that. So like today, to sell across state lines, so to speak, you would have to go and get licensed in Iowa, which carriers can do that, and they do that. The bigger issue is really, quite frankly, on the provider side, having a network and meeting the standard of network adequacy. So there's a multi-layer here. It's part of it is, could there be better across state lines? Would that help on competition? Absolutely. But I wrote about this a long time ago. It's not the panacea unless you also address the other side of it, which is, okay, can I, as a new carrier coming to Iowa, actually have a network that's adequate to serve the people in Iowa? Can I get the right prices to be competitive with the docs? And so there's those issues as well. So I think you have to look at it both on the provider side, the insurance side, and then some of the naysayers, which I don't really add a lot to this. It's like, well, hey, I'm just going to I'll pick on Alabama because they have the fewest mandates,
right.
And then I'm going to issue policy over there. Could that happen? Maybe, I suppose, because there are a lot of states that put a lot of mandates on these policies. Now, that has slowed down, I think, since the Affordable Care Act passed, but there still happens every session, I'm sure, somewhere where a legislator decides that they need another mandate of some kind, and some of those actually have value. But the reality is, if everything you put into these products, it just blows the cost. And It goes back to our earlier point was, is this really insurance, or are we just basically passing through healthcare spend? Yeah. And so I do think, going back to the innovation point, I feel like there's a lot of opportunity, not just potentially having more carriers and having competition, but product design, network adequacy. You have to look at it in stages and say, maybe not everyone needs a gold tiered plan, and maybe my idea for my family is a little bit different than your family. And understanding that a lot of the market is already government paid through, VA, Medicare, Medicaid. Another huge chunk of the market is through self-insured large groups. So a lot of the stuff we talk about is really, I'd say, only impacting, but not impacting as many people, because it's the individual and maybe the small group market that gets kind of, I say penalized, but hit the hardest. Because I, as a large group self-insured plan, have a lot more flexibility in plan design. And then I can even, throw in the HSAs and things of that nature, a little bit more flexibility. And actuarially speaking, an employer group on average is healthier. So, you do have to step back and say, this is a multi-level problem.
And weirdly enough, right, it's a situation in which, if you just keep it at the state level in terms of these, even, with these compacts that are out there, it's only the biggest carriers and providers, the biggest companies, that can offer individual products in these states. So it doesn't allow, there's not real competition that's out there, because they can't while these guys are competing across state lines. You folks can't see it, but I'm using air quotes here. They're not really competing, because they're just following the individual mandates of each of those states, aren't they?
There's a little truth. Yeah, I think that's pretty true. And I think the other thing is, like in Iowa, we have one large blues plan that has a significant market share here. And then we also have a pretty large market share in South Dakota, but they're only in 2 states. Yeah. But, they're part of the blues plan, and folks would put, right, wrong, or indifferent, they would put blues under one umbrella. And there are several different states that have their own version of the company. But you're right. I mean, whether it's United, the biggest companies, CVS Caremark, on the Cigna, these are large companies, but some of them have little niches. So like Cigna might be much more just helping the employer market. Right. United might be in Medicaid, employer, and individual. But really where they have the most power is because they have so many members, as collectively, to your point, they can really drive volume and sit down with that provider in whatever state and say, you know what, we have access to 200,000 lives in Cleveland. And do you want to, I mean, so they can have different negotiating power, I think, obviously. And, then they have the ability to really kind of help and drive those conversations versus, let's say, you and I decide to start up an insurance company. To be honest with you, there's a few people trying this kind of stuff now, which is exciting. We're starting from scratch, and we got to go, pound the pavement literally and find the docs. And, why would, Nick and Andrew's medical clinic do a deal with this other care? I mean,
absolutely.
There's all these conversations. And so, most of the volume, whether it's, Medicare Advantage, managed care, employer, self-insured, it is really driven by a small group of players. And so it is hard to see these kind of startup companies get out there because you're competing with the biggest of the big. And like anything, it's the David versus Goliath conundrum.
Sure.
And so, that's why I think while the idea of across state lines is very intriguing, I do feel like if you had 500 carriers competing or even 50 in some of these markets, you could probably bring down premiums. But you have to address the other side of it, which is that provider side.
Right. And that actually gets into my question. I mean, setting aside the widget and both medical school billets and residency programs, but let's also talk about the issue of cross-state licensing, because this is the question that my wife had for me, which is, as I was telling her about this conversation that you and I had and several of our colleagues. She goes, well, how does it work in terms of my licensing? Where am I licensed, or what are the requirements there? I mean, listen, I think one of the things we need to be doing in America is finding ways, one of the products, for instance, that I think could be very helpful in terms of things like radiology is, cross-state licensing, multi-state licensing for folks, right? There's no reason why if a radiologist in Kentucky had some spare time and there was a rural clinic in Alaska that needed somebody to read charts or read x-rays, read images, why they couldn't be able to do that. This is the same kind of a thing. So how do we deal with this? I mean, is this also part of what we need to be doing, is looking at ways to make sure that licenses are accepted across state lines?
That's a great point. We kind of touched on that when we talked before, and I've thought a lot about that. Yes, I think that example you just had about maybe there's communities that have a hard time finding specialists. Right. Absolutely. And someone that's credentialed and in radiology, I mean, I'm guessing the scans in Alaska look pretty similar to Iowa and vice versa. So I think there is definitely a need there. And then there's also the need of, getting that individual credentialed and ready to go with that payer too.
That's what I'm saying. That's where I was really going.
You got the payer side, you got the state side. And to me, it's like, this is where innovation really could do a lot to help these folks, because there are platforms out there.
And hold on, let me flip it around for a second there, Nick, because I'm being parochial in saying a physician in Kentucky reading charts in Alaska. By the same token, right? I mean, somebody could be in a rural community in Iowa, or a doctor may want to move to a rural community in Iowa or South Dakota or Alaska or wherever, and should be able to do work, elsewhere, right? In places like New York or California, where there may be an overburdening, not enough doctors to go around, right? This is a way of solving that problem of getting the physicians where they need to be. Me sitting here being parochial. How dare I be? That's DC thinking for you. Sorry, Nick, go ahead.
But no, and again, I mean, I think it could absolutely go both ways. And obviously not every doctor and specialty would have that flexibility, because there's going to be some on-prem you have to go do,
right,
clearly. But there are some specialties where you could absolutely see doctors working from anywhere.
Right.
And think about your profession, what I do. I can be as effective, sitting on the beach of Hawaii, probably not Hawaii, but I can be as effective sitting somewhere else as I am and vice versa. Some of these docs and specialists would have that same ability. And so I do think there's that, but I go back to at the end of the day, insurance, as it's envisioned, is pooling a group of people together, transferring risk to somebody else for things you can't afford to do or want to lay off on somebody else. And then I still think the bigger problem comes to the heart of the Affordable Care Act, which is like, we're very prescriptive on plan design. We're going to be very prescriptive on medical loss ratios and all these things. I think there's so many opportunities to look at this and say, do the plans out there, are they meeting the needs of the consumers today? And I would tell you, I've heard the conversations. If you're not getting the tax credits, you're paying upwards of $40,000, $50,000 a year
Right.
for a family of 4 or 5. Which, here in Des Moines, that's a heck of a lot of money for a family,
Right.
even if you're making good money.
No, without a doubt, it's again, it sort of gets down to this. When we got off the phone, we had a call. Nick and I talked last week. And I was on the phone with a colleague of mine, something I'll say it, Jerry Rogers, who is, he also does a podcast for us at the Federal Newswire called The Business of America. Jerry's the editor of Real Clear Health. And as we're sitting there on the phone, or I'm talking about the conversation that we had, we both sort of did some math in our head. Never do math on the air, Nick. Just so you know, never do math on the air. But, and you shouldn't do math on the phone, but we sort of were spitballing here. And we really came to the conclusion that, you really could have a cost savings of about 20%, just sort of noodling through what everything does here and what might change. And that's what we're getting at here. Again, coming back to $5 trillion spent on healthcare in America. We're talking about substantial savings that some of it is passed on to the consumer, and some of it is plowed into the business in terms of innovation. Some of it could go to greater attraction and recruitment and retention of providers. But every bit helps, doesn't it? That's, I guess, my point in all of this is that every bit helps here, and we shouldn't poo-poo it because it's not, as you said, the panacea that we were talking about.
I think you are going to have, I'm a big, let's take a small knife, an X-Acto knife, and take it, because to your point, you can get to that sledgehammer result of 20, 25%, I think, easy. And because the amount of dollars there, it's not an amount of money spent that's the problem. It goes back to anything. It's where are the resources going?
Yeah.
Waste, fraud, and abuse. There's been a lot of research out there about Medicare fraud and abuse and Medicaid fraud and abuse. And one of the things I worked on early out of law school was, kind of Medicare and Medicaid fraud cases. And, and sometimes I would argue that provider, because it's such a crazy system of billing through the coding system, they might not even do it intentionally. So, people don't understand, like, if you're running a healthcare operation today, your technology spend, the billing spend, the chasing down, all the things you have to do. I'm on the board of a group called Child Serve, which is a very large nonprofit here that helps kids with special healthcare needs. You spend a lot of time arguing with Medicaid providers, managed care companies, and they have a whole team of people that's pretty much what they do. And so there's got to be ways to streamline this on payments, on AR, receivables. But there's no way you can save 20% over the next couple of years if you were to lean into this and start to say, okay, what's the first problem we're going to solve? Senator Grassley, our senator, always say, the best way to eat an elephant's one bite at a time.
It's something I say to my kids all the time. How do you eat an elephant? One bite at a time. Absolutely true.
And it adds up.
Yeah, 100%. Well, that's right. Listen, it's a one-off on the old adage, a billion here and a billion there, and pretty soon you're talking about real money. That's absolutely true. So listen, before I let you go, I do like to do this. When I'm talking to folks, I do 3 podcasts, and nobody should do 3 podcasts.
That's a lot.
But yes. But I was at one point contemplating doing a podcast centered entirely about talking to people who are involved in politics and public policy. And I know you're involved in the business side of things, but you are from a public policy background. Talking to them about the things that are interesting to them outside, their outside interests. So when you're not working, when you're not doing this work, your COO work with Homesteaders Life, what are you up to? What are some of your outside interests?
Yeah, I'm pretty boring. We've got 4 children, oldest in college, my youngest is 8. Wow. So I play tennis, I play a little golf, I like to go fishing. We got a lake place about an hour outside of Des Moines. Do a lot of fishing when I can, and then I read a lot. So I'm a stock market junkie too, unfortunately. So
nothing wrong with
a lot of time looking at stocks, and I've gotten away from day trading, over the last few years finally. But and I didn't get any meme stocks back in the the COVID days. But I do have a lot of interest in the stock market and how things work like that.
Well, listen, I appreciate that very much. It's always good to get the perspective of somebody who is not just outside, but well outside of DC on these things. I really, really appreciate it. Thank you so very much for joining us today.
It's great to be with you. Thanks for having me.
And how do folks find out more? I'm sorry, I should have said this. How do folks find out more about the good work that you're doing?
Probably LinkedIn's probably I haven't been posting much the last few months because we did a large transaction, but I would say LinkedIn's probably the best way to find me. I'm probably pretty active on there from time to time. So I got off Twitter, now X. I still read some stuff and follow people, but I try to stay off of that.
No, I get it. Believe me.
So LinkedIn is my place.
That's LinkedIn is your jam.
Yes.
Do you, real quick, because just as an aside, do you ever go and look at who is looking at your profile?
Oh yeah, once in a while. It's pretty interesting.
I got a note from a friend of mine. She's like, why is anyway, somebody, an attorney with something, why is this person looking at my profile? And then I said, I guarantee it's because somebody else suggested you as a possible date. This person's single, and they were stalking you on LinkedIn that way. And she I don't think really believed in me. Anyway, Nick, thank you so very much for joining us today.
Thanks for having me.
This has been yet another episode of the Lunch Hour with Federal Newswire. You can check us out on the many fine podcast platforms, wherever you get your podcast content. Check us out there. If you're listening to us, you can also find us on YouTube, see what's happening in the studio. Hit the subscribe button, leave us a like, leave us a comment, and most importantly, let your friends and family members friends and friends, family members know how much you're enjoying the Lunch Hour. I'm Andrew Langer. Enjoy the rest of your lunch.
This has been the Federal Newswire Lunch Hour podcast, hosted by Andrew Langer. Check out the Federal Newswire's family of websites, as well as their social media stream